internal anticoagulant. It stops platelets from having the ability to just stick to any endothelial cell that they want to stick to. Prostacyclin, however, is made only by COX-2. So this is why if you're on a COX-2 inhibitor for up to 18 months, they suddenly saw a cardiovascular risk. That means more strokes, more MIs, which is why the warning, do not use these drugs beyond 18 months. Very, very important. Why do we not see it with the NSAIDs? There's a small risk, maybe 1%. But that's because they're non-specific, whereas the COX-2 inhibitors are much more specific. So what do we use prostacyclin for? We use it for treating pulmonary hypertension, especially primary pulmonary hypertension in middle-aged women. You can use it there. Very expensive drug, however, but it does work. Currently, it's not the drug of choice, but it is a drug that can be used for pulmonary hypertension. What about prostaglandin F2? Prostaglandin F2 is a vasoconstrictor. Prostaglandin F2 is a vasoconstrictor. 3 places you need to be aware that it plays a role. Number 1 is dysmenorrhea. Painful menstrual cramps every month is caused by prostaglandin F2 vasoconstricting the uterine arteries to allow the lining to slough off. Well, ischemia causes pain, which is why NSAIDs such as naproxen is used to treat dysmenorrhea. Second place, to allow the placenta to slough off after a baby has been born. Third stage of labor, bring that placenta out. Should take less than 30 minutes in every pregnancy. That's prostaglandin F's job. But it makes sense to you, therefore, why we don't want pregnant women on aspirin or NSAIDs, especially in that 3rd trimester. Now you understand why. Prostaglandin's got to be allowed to do its job. Now, what about drugs that mimic some of these things? Very good question. So we talked about alprostadil, that is a form of prostaglandin E, to open up a patent ductus arteriosus. Well, there are other drugs, forms of prostaglandin E, all right, misoprostol, used in the stomach for aspirin or NSAID-induced gastric ulcers. There's another one called dinoprostone. Dinoprostone is used as prostaglandin gel to induce labor. There's prostaglandin F analogs. One is called carbaprost, used as an abortifacient. Another one is called latinoprost, used for severe glaucoma. It has a unique side effect, though, of causing growth of very long eyelashes. It turns out about 10 to 15% of people who use it grew long eyelashes, but it's temporary. So that when you stop the drug, the eyelashes go away. So these are the prostaglandins that you need to know and their functions. The leukotrienes and their functions. By taking your time and learning these, it helps you understand why arachidonic acid is a very important fatty acid in your body, and why you need the essential fatty acids to be able to liberate arachidonic acid from the membranes of your body. Quick review on everything that you just heard. So the prostaglandins, prostaglandin A2, also known as thromboxane, made by platelets, causes vasoconstriction and also enhances platelet adhesion. This is the one you're trying to block with aspirin for acute coronary syndrome or anybody with a coagulative disease. Aspirin is the most effective antiplatelet drug on the market. All right, prostaglandin E2 is a vasodilator 80% of the time, vasoconstrictor 20% of the time. This is why if you're going to give this to a woman of childbearing age, you better do a pregnancy test. because vasoconstriction can lead to an abortion. In the kidney, it dilates the afferent renal arteriole, so it provides blood supply to the kidney. This is why aspirin and NSAIDs can cause renal failure. In the heart, it keeps the PDA open. This is why we give alprazolam, a form of prostaglandin E, to open up a PDA if a child has cyanosis in the first 48 hours, which means they have a cyanotic heart disease. In the GI tract, enhances mucus production by the gastric lining. So we have drugs like misoprostol, which can take its place if you have aspirin or NSAID-induced gastric ulcers. Prostaglandin I2. Prostaglandin I2, known as prostacyclin, primarily a vasodilator made by all your endothelial cells. Its job is to block platelet aggregation, but is made specifically by COX-2. This is the mechanism by which specific COX-2 inhibitors, celecoxib, rofecoxib, valdecoxib, created cardiovascular risk if you use them for up to 18 months. And then prostaglandin F2. Prostaglandin F2 is primarily a vasoconstricting molecule. In the GU tract, it's responsible for dysmenorrhea, painful menstrual cramps every month. Drug of choice, naproxen. Number 2, separates the placenta after delivery of the baby, third stage of labor, which is why we try to avoid aspirin and NSAIDs in the third trimester of a pregnancy. Third is abundant in semen. Abundant in semen, which is why intercourse, vaginal intercourse in the third trimester could precipitate early labor. And now the leukotrienes. We said there's 2 of them you need to know. Leukotrienes C4, D4, E4, also known as slow-reacting substance for anaphylaxis, is made by mast cells. It's made 4 to 8 hours after an inflammatory response, so it's called a late phase of allergy. This is the most potent bronchoconstrictor and vasoconstrictor that we know, which has led to many deaths in the past. So we understood why it's very important to give steroids to allergy sufferers or give steroids to an asthmatic patient. Very, very important. And that's why we have an enzyme called aerosulfatase to break down SRSA so that it does not get out of hand. If you are deficient in aerosulfatase, that enzyme deficiency will lead to a disease called metachromatic leukodystrophy, which is a multiple sclerosis-like disease, but in a 5 to 10-year-old child. The other leukotriene they want you to know, leukotriene B4. Leukotriene B4 is a strong chemoattractant for neutrophils, along with interleukin 8. And now we go into the pharmacology. Once you understand normal, folks, pharmacology becomes easier. So we're going to review a lot of pharmacology that has to do with what we just discussed. First one is aspirin. Aspirin is used for 4 different reasons. Analgesic, pain relief. Antiplatelet drug, which we've discussed immensely now. Anti-inflammatory, and then antipyretic. Aspirin, used for those 4 things. How about side effects? Side effects of aspirin has to do with gastric irritation. So you got GI irritation, GI bleeding, GI ulceration. In your stomach, remember it's still fat soluble. When it gets absorbed, it's still fat soluble for about 20 minutes. So what do you get from that? If it runs by a platelet, it acetylates the platelet membrane, causes platelet destruction, so thrombocytopenia and all the problems that come from that, like bleeding from the skin and mucosal surfaces. This is how you get synchronism. If it acts as a hapten on the surface of a platelet, then your body has to make antibodies against the platelet. You get thrombocytopenia, tinnitus, and hearing loss, which we call synchronism. Remember that aspirin and all the drugs which have quin somewhere in its name, like mefloquine and chloroquine and primaquine, they can also cause synchronism. Aspirin now have access to your brain because it's still fat soluble for the first 20 minutes. Any acid in your brain will make you breathe faster. And if you breathe faster, your PCO2 comes down, your pH goes up, which is why respiratory alkalosis is the first blood gas seen with aspirin ingestion or aspirin overdose. Respiratory alkalosis is the very first blood gas seen with aspirin overdose. Now, what happens after 20 minutes? After 20 minutes, you're going to see the protons of the aspirin start to dissociate. If the protons dissociate, now you get metabolic acidosis. And you got metabolic acidosis, it makes you breathe faster, so now you have a respiratory alkalosis that's even worse. So that's why you have a combined metabolic acidosis and respiratory alkalosis as the number one and most common blood gas seen with aspirin ingestion or aspirin overdose. And then you get complications from there. After it's dissociated, now it's water soluble. So where's it going? To the kidney. And in the kidney, it can now cause renal failure, interstitial nephritis, and acute tuberous necrosis, amongst other things. Now remember, the Rye syndrome that we discussed is because when aspirin came through the liver, it was still fat soluble. And if you were a child with a virus in that liver, the liver had a hard time handling the virus detoxification and the drug detoxification. Notice you hardly ever hear about Rye syndrome anymore. And you have not seen a case in decades. That was because children were taking too much aspirin in the past because moms were giving them a full dose of aspirin, which is way more than anybody needs as analgesia or as anti-inflammatory. 80 to 100 milligrams were the doses used in most studies. So, a lot of side effects of aspirin, but notice I tried to talk you through it so that you start to see how this information comes out. This way you're not trying to memorize them as details. You won't remember them after a while. So now you know the 4 reasons we use aspirin. Now you know how to figure out most of the side effects of aspirin. How do we treat aspirin overdose? Well, since aspirin is an acid, that means it's water soluble. First thing you do, give them fluids, normal saline. Second thing you do, give them bicarb. Ionize the aspirin so that you can easily urinate it out of your system. So aspirin overdose. Now it doesn't seem so hard, folks, to understand these drugs. Well, what about reversible cyclooxygenase inhibitors? Remember, aspirin was irreversible. NSAIDs are reversible cyclooxygenase inhibitors and also nonspecific, like aspirin. So that's why aspirin and the NSAIDs have almost the exact same side effect profile. The only difference is NSAIDs don't cause Rye syndrome and they don't cause syngenism. But almost everything else they can cause. But again, that makes sense. So the NSAIDs that you need to know with clues. Indomethacin is the most potent NSAID. Indomethacin is also first-line treatment for gout. Indomethacin was also used to close a PDA. Ibuprofen is the main NSAID over the counter. Naproxen is the NSAID, which has a high sodium load. Remember that, it starts with Na, sodium. And is also the drug of choice for dysmenorrhea in a female with painful menstrual cramps. Baclofen is the NSAID with GABAergic effect, meaning it enhances GABA, which relaxes the tight spasms that people get from back pain. And that's how it got its name, baclofen, back spasms. Ketorolac is the NSAID with the strength of morphine for analgesia. When would I need to know that? Let's say you have somebody who's a known heroin addict. The last thing you want to do is bring back the heroin addiction after they've worked so hard to break that addiction. And that happens. However, it would be unethical because of their addiction history that you would withhold good analgesia in the form of opiates simply because they were addicts. You would simply discuss the need for the opiates with the person, because there is a chance their addiction may come back. But you cannot withhold good analgesia when the patient is suffering. But there's a drug called ketorolac, which has the same strength of morphine for pain relief. And therefore, you're not being unethical. That's where ketorolac is used. Then we have diclofenac and ketoprofen, the first two topical NSAIDs on the market. You just rub it on wherever it hurts. The good thing is that it does not penetrate the stratum corneum, so you don't have to worry about systemic side effects. Again, diclofenac and ketoprofen. And then finally, Sulindac. It starts with SUL to remind you that there's sulfur in it. So make sure, folks, you are well aware of the allergic reactions caused by sulfur drugs, because there are so many drugs we're going to be talking about over time that have sulfur in them. Well, the next group of drugs to talk about are steroids. Steroids are the most potent anti-inflammatory drugs we use as physicians. And we use lots of it because we have so many autoimmune diseases that have inflammation and we have to treat them. Well, on the left side, what did I do? I put the anti-inflammatory actions for you. The mnemonic we use here at the program is IKISS. I stands for inhibit phospholipase A. K is to kill off the T cells and the eosinophils. This is why it helps in suppressing inflammation attack against an organ. But this is also the same reason why you're immunocompromised. If I kill off eosinophils, that's why it works in allergies. But it also puts you at risk for parasites because eosinophils are needed for that. So there's good and bad with every drug you give any patient. You as a physician just need to make sure you understand it before you start a drug. All right, IKISS, that's I and K. I inhibit macrophage migration. The macrophages cannot come into the area, they cannot process any antigens. S, stabilize mast cell membrane so they cannot degranulate, cannot release their inflammatory mediators. S, stabilize endothelium so that fluid cannot leak out and macrophages cannot enter the tissue. This is why we use steroids for things like cerebral edema. See that? Or laryngeal edema. Or edema of any type. If you want to stabilize endothelium, steroids can do that for you. So IKISS are the 5 anti-inflammatory actions. Then we also have the physiologic actions of steroids. That means you break down proteins and turn amino acids into glucose. We call that gluconeogenesis. So in general, proteolysis for gluconeogenesis. This explains why they are hyperglycemic. This explains why they get insulin resistance. This explains why they get type 2 diabetes from these drugs. See? And that means that if you got a diabetic on a steroid, you got to know you're about to make their diabetes worse. You got to know you're going to need to tell them to take more medication. But that means for any protein in your body, it's going to start to degrade. This is why they say be careful about injecting steroids into a joint or a tendon or cartilage, because in the long run, it's going to break that protein down. This is why they get striae on the skin from breaking down skin. This is why you get tendinitis and tendon rupture, because you're breaking down tendons. This is how they get arthritis as a side effect, because you're breaking down cartilage. This is how they get myopathy and myositis, because you're breaking down muscle. This is how they get osteoporosis, because it's breaking down bone. You see, you can figure out the side effects if you knew the actions. Knowing the actions of a drug is a shorter list. Trying to memorize hundreds or thousands of side effects of a drug, no, that's not very wise. So these are the steroids that you need to know, their clues. Prednisone is the main oral form. Methylprednisolone is the main IV form. Triamcinolone is an inhaled form. Budesonide and cyclosinide have smaller particles, so great for small children. Beclomethasone and betamethasone are used to induce surfactant in a premature baby. But currently, we prefer dexamethasone because it crosses membranes faster, which means it'll cross a placenta faster to get across to the child. Hydrocortisone is topical and injectable and also used to take the place of cortisol in anyone with adrenal insufficiency. Hydrocortisone is now used to take the place of cortisol in anyone with adrenal insufficiency. Dexamethasone crosses membranes faster than anybody else. This is why we use dexamethasone, let's say for meningitis, to decrease the amount of swelling of the brain, the amount of inflammation you're going to get in the brain when you have a bacterial meningitis. This is why when you have metastasis to the central nervous system, we use dexamethasone first and then radiation to follow. The dexamethasone shrinks the swelling around the metastatic lesion and therefore less compression of the nerve. Think about why we use dexamethasone for the dexamethasone suppression test. See, because the brain again is involved. Fludrocortisone, notice it has fluids at the beginning. Fludrocortisone is a steroid used to treat anybody with adrenal insufficiency. It takes the place of aldosterone. Next one, cyproterone, is used to block dihydrotestosterone receptors. That's if you don't have flutamide available. Megestrol is a steroid with anabolic properties, which means it increases the appetite of the patient to whom it's given. So we use megestrol to increase the appetite of cancer patients. It's also being used now in AIDS patients for the same reason. Fluticasone and mometasone are both used as an inhaled nasal allergies. So they come as nasal sprays. And then danazol is a steroid that's used in the treatment of endometriosis. It's very androgenic. So you're throwing off the balance of that female. By making her more androgenic, she has less of the estrogenic effects. But then you can understand the side effects are masculinization. Increased muscle mass, increased appetite, increased weight gain, memory loss, hair growth. See, things start to make sense when you understand the actions of a drug. Which now brings us to the next group, which we call mast cell stabilizers. 2 drugs here. Cromolyn and nidacromyl are the 2 mast cell stabilizers. These are used primarily in children, but they come as eye drops, nasal sprays, or inhalers. The good thing about them, the only side effect is GI upset. So here's where I review the current management of asthma in America at this point in time. There's 5 levels that we now use. Very important to take notice of these. First one is mild intermittent, which means you get symptoms maybe once or twice a year. That's it. For that one, treatment, use a beta-2 agonist like albuterol inhaler as needed. You don't need anything very potent for that. Second level, mild persistent. That means if you have more than 1 use of the inhaler a day, if you have more than 1 flare-up in a week, or if you have 2 or more flare-ups in the night, or hospitalization, more than 1 hospitalization in a month, you're at this level. What do we need to do for you? We put you on a steroid as an anti-inflammatory drug and a beta-2 agonist, short-acting beta-2 agonist. Now, what they've done is break it up by how old you are. Under age 5, we prefer you be put on cromolyn and nidacromyl inhaler every day, and then a beta-2 agonist as necessary. But if you're 5 or older, we prefer you be on a steroid inhaler every day, and then a short-acting beta-2 agonist as needed. This is the second level. At the third level, you're still having symptoms. So now it's moderate and persistent. What do we do for you at this point? These were the studies that revolutionized treatment of asthma. It was the use of long-acting beta-2 agonists, LABAs. So they found that long-acting beta-2 agonist plus steroid combination was better than either one by itself. So once you get to moderate persistent, folks, the person needs to be put on a long-acting beta-2 agonist plus steroid combination, and still they must carry around their short-acting beta-2 agonist for emergencies as needed. If you're still having symptoms, level 4 is severe. We then go to oral steroids. Start out with a high dose for 2 to 3 weeks and then start tapering off, because it means you need to really squash all the inflammation that's going on. And then the final level, level 5, is when a patient is still having symptoms, despite everything we've done all the way up to level 4, then you can put in a monoclonal antibody which blocks IgE, which is involved in an allergic reaction called omalizumab. So 5 levels. The key is to learn them, understand them, and therefore in the vignette, they'll describe the patient, tell you what's been going on, and you'll be able to figure out exactly what level they're at and what medication you need to give them. What about leukotriene receptor blockers? There's several of them on the market. They all end in Lacast if they block the receptor. The one that's called Xylutin is the only one that blocks the actual enzyme lipoxygenase. What do we use them for? You can use them at level 1 by themselves when symptoms are real mild, or in addition to the other treatments that we just outlined at any other level. Because by themselves, they were not able to control asthmatic symptoms at the other 4 levels, only at level 1. So leukotriene receptor blockers. All right, now we've made our fatty acids. How do we turn them into triglycerides? To turn them into triglycerides, we now start with glycerol 3-phosphate. In the liver has its own enzyme called glycerokinase, which can make glycerol 3-phosphate from glycerol by using ATP. The other organs tend to use dihydroxyacetone phosphate, or DHAP, and then reduce it to glycerol 3-phosphate. Now, that means we have 3 carbons, but a phosphate is attached to 1 carbon. Here's how we proceed. We add a C16 to carbon number 1. The rule there, no double bonds are allowed at carbon number 1. That structure with C16 at carbon number 1 is called lysophosphatidic acid. What if you add a C16 at carbon number 2? The rule there, you have to have at least 1 double bond. You can have more, but you have to have at least 1. So unsaturated. That structure there, we now call it phosphatidic acid. Phosphatidic acid then becomes the backbone for our complex phospholipids. Meaning we're going to modify it from here by adding other things to phosphatidic acid. So what things are we going to add? Okay? Remember, we need a carrier to add things. So what we're going to add, our carrier will be CDP. Remember, we've talked about other carriers. UDP is a carrier for 1 sugar. Dolichol is the carrier for multiple sugars. But CDP is going to be our carrier now for complex lipids. So 3 things I'm going to illustrate for you. CDP will be carrying all 3. Ethanolamine. So add that to phosphatidic acid, you now have phosphatidylethanolamin, which is used to create receptors of the brain. If CDP brings choline, now you have phosphatidylcholine. Phosphatidylcholine is used as lecithin to emulsify your fats in the GI tract. And if you modify it some more, it's used to make surfactant in the lung. Again, that's phosphatidylcholine. Well, if you modify it with serine, now you have phosphatidylserine. What is that for? It's a marker for apoptosis in any of your cells. Remember the gene that controls apoptosis, P53. The protein that controls apoptosis, D-cyclins. The label for it we just created, phosphatidylserine. And the enzymes recognize the label, remember, caspases, and then they'll digest that cell. If you wanted to label a protein to be destroyed, we call that ubiquitin. And the enzyme that places on it, ubiquitin ligase. Just keeping you reviewed. So we made phosphatidylethanolamine, phosphatidylcholine, phosphatidylserine. CDP was our carrier. So what if we get rid of CDP and bring in something else? Bring in another molecule of glycerol 3-phosphate. Hook them together with a phosphate bond or phosphodiester bridge. Folks, that's how you make cardiolipin. Remember cardiolipin? Cardiolipin is a marker seen in lupus. Very important marker seen in the disease lupus. But now at least you know what cardiolipin looks like. Now, if I take away the structure that I just brought to it, take away the phosphate from the glycerol 3-phosphate, and just add a hydrogen to that oxygen, now you have diacyl, 2 fatty acid chains, diacylglycerol. And diacylglycerol, DAG, is part of the IP3-DAG second messenger system. Who uses it? All smooth muscle contraction caused by a hormone or neurotransmitter. Who else uses it? All your hypothalamic hormones except CRH. See? At least now you know what that looks like. And then if you remove the hydrogen, the OH group altogether from that third carbon, add another C16, what do you have? Triglycerides. That means 3 fatty acid chains. So 3 palmitic acids added at each carbon. Now we call it triglycerides. So the next thing you got to do is digest the fatty acids in your diet. Pancreatic lipase will help you digest those fatty acids. Once you break it down into smaller pieces, then you can break it down into long, medium, and short-chain fatty acids. Absorb it through the GI mucosa and send them through the lacteals on their way to the liver. Well, a drug called orlistat can block that for you. Orlistat works by blocking pancreatic lipase, and therefore you cannot digest your fats. And the whole theory behind that drug was you can eat the fat in your diet, but you cannot digest it, so you cannot absorb it. The problem was it causes steatorrhea and malabsorption, which is not very pleasant. So a lot of people had accidents in their pants, which they were obviously furious about. But because of malabsorption, they created a low energy state for themselves. They create a problem with all the fat-soluble vitamins. They create a problem with all the steroid hormones. So you see, you can figure out a lot of things just by knowing normal physiology.